Top Med Talk.
Welcome to Top Med Talk here at Anesthesiology 2025. We're in San Antonio, Texas for the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell. I'm your host and co-editor-in-chief of Top Med Talk, and my co-editor-in-chief of Top Med Talk, Professor Mike Grocott.
Thank you, Desiree.
Yeah, Mike, over the last couple of days, we've had phenomenal conversations with people from all over the world, honestly, hearing about what's the latest and greatest in anesthesia.
All sorts of things, clinical trials, practice management, hemostasis. The topics have been really fascinating.
Yeah, they have. We've also really had the chance to catch up with leadership within the ASA, the American Society of Anesthesiologists, to hear about what's happening as far as workforce, like the economic climate right now in anesthesiology. And it's always one of our favorite parts of the meeting to hear a little bit more about what's happening within the organization. So we're really excited about our guest today. We have Dr. Sheila Barnett joining us and Dr. Patrick Guffey joining us to talk about the Anesthesia Quality Institute, which we have had previous conversations about. So Dr. Barnett, Sheila, if I may, thanks so much for joining us.
Thank you very much for having us. And it's just great for AQI, Anesthesia Quality Institute, for us to be able to talk a little bit more about some of our initiatives. Yeah. I'm an AQI board member, and I have a long interest in quality in anesthesia, and I'm currently the chair of anesthesia at Dartmouth in New Hampshire.
Fantastic. And Dr. Guffey, Patrick?
Yeah, honored to be here. Patrick Guffey. I serve in a few different roles. At the University of Colorado, I'm a professor in anesthesiology and practice pediatric anesthesia. And then for Children's Colorado, I serve as a chief medical information officer and an informaticist, and been working with Epic for about 15 years.
Oh, fantastic. Lots of experience there. In the past several years, we have had lots of conversations with Dr. Randall Clark and Mark Berenstein, and those really part of the AQI here within the ASA, and heard a lot about what the organization is doing to support clinicians to be able to enable them to submit MIPS. So we talked a little bit about MIPS and merit-based incentive program, and learn a lot more about quality and what we're doing and how we impact quality. So for our listeners that may not have heard those, Dr. Guffey, Patrick, would you like to tell us a little bit more about the AQI and how you're using data to help clinicians and improve quality of care?
Yeah, so the work of the AQI has been an evolution over time. It really started with one primary registry, which is called NACO, and NACO, the National Anesthesia Community Outcomes Registry. And the purpose of that registry was really to learn about what's going on in our specialty and then give us the information necessary to improve. And then AQI runs a couple of other registries. One I'm really familiar with. I get the privilege to serve as the chair of it, which is the Anesthesia Incident Reporting System, which is where we get information about all of the either near misses or cases of harm that come in that happen to our patients. And then we produce an article in the Monitor every month that looks at a case. And then finally, the closed claims database was adopted into AQI. I think it was back in 2018, if memory serves. That came over from some work that was done out of Seattle. And that's a really powerful database because it looks at what was litigated and closed. Cane was closed out and what the result of that was. Now, where we've had opportunity is going back to NACO. NACO has really been collecting a lot more of administrative data than clinical data. And the reason for that is that data just happens to be a lot easier to get. The way the surgeons have been able to do this is with a lot of manual abstraction. That's how NISQIP and other registries work. We've always approached this from the space when Rick Dutton was in charge of the AQI back in the day, that we need to be able to get electronic data because we don't have those same resources of asking the hospital to hire 5 abstractors for everything and go through the chart. As you might imagine, that's given us a lot of administrative data because billing and coding and all that tends to be very discrete structured data. What our evolution has been is how do we get the clinical data so that we can answer a few key questions? We're really trying to frame this now as an outcome registry.
Yeah.
So what we really want to be able to do is answer the questions that, when you think of an anesthesiologist doing a case, there's certain things that we're doing that probably have implications that we don't know about. And there's other things that we're doing that probably don't matter. And when you're trying to influence how anesthesiologists provide care, physicians in general want to see some evidence. So we need to be able to produce that evidence and say, we'd like you to standardize on these things because we have good evidence that this helps. But when it comes to these other things, do whatever you think is correct between you and the patient, because we don't have a strong preference based on the data. And we need to be able to provide that service. And we need also to be able to, in this financial climate, we need to be able to determine value.
Yes.
So if you think of that equation where you've got the service times the quality of the service divided by the cost of the service, that's value. And for far too long in medicine, I don't think that cost component has been figured out. So if we do an intervention in anesthesiology as part of our practice and we see a very slight benefit that has a very high cost, we need to be able to communicate that to our community and say, for most patients, you're adding cost to an anesthetic and you're not getting a huge benefit out of it.
Yeah.
Those are the questions we want to answer.
That's great. Sheila, I wanted to ask you, Patrick made a point that many times that we may not understand what the outcomes are of the care that we're delivering. And I mean, to me, this is it's kind of a black box, right?
Yeah.
So you take care of your patient, you drop them off, and you may never see them again or know anything that happened to them. So tell me about how AQIs, they're working to address that, because it really is tough.
Right. No, I think it is tough. Ironically, I always think in anesthesia, unfortunately, the best anesthetic is the one you remember absolutely nothing about and you have no recall and it was great. Hard to look back to what we should have done differently. So I think what the opportunity for NACO is and for AQI is, we get data on maybe how you do 10 days afterwards, 6 hours afterwards or whatever, but the anesthesia itself has often been a bit of a black box. Because to your point, from a paper record, it's really hard to extract what the blood pressure was or what time you really gave the med or what time the intervention really was. So I think this will allow us to get much more granular data on what we're doing and what we control, as opposed to just being I feel like we're batched in with complications of surgery.
Yeah.
Lap choles, ACS data from the American College of Surgery, we're kind of batched into that as was it general anesthetic or regional. This will allow us to have a lot more granular data on, well, did those drugs like dexmedetomidine really make a difference? Or did they prolong things? And then getting back to the value-based, I'm really into geriatric anesthesia, and that's where, we have hundreds of patients overwhelming the system in a way. Shaving off a day length of stay and stuff like that is a huge thing for overcrowded hospitals. And so what can we do in our anesthetics or that preoperative, perioperative part beforehand to prepare the patient to get them in, get them out, and ideally remember nothing. But I do think there's a lot of opportunity. And I think there's just that we really need to, many of us are very competitive, I think, in medicine, want to kind of do a little better the next time. I think it's fun to be able to actually use data to say, hey, this was actually better. Last month in July, we introduced something. In September, we can look at it and say, hey, you know what? That did make a little bit of a difference. Or we did see something on the cost factors there.
It does give us an opportunity for continuous quality improvement. It's
correct. Right. It allows us to control it a little bit more. Yeah. As opposed to just sort of being passive recipients of data and stuff. So I'm really into the idea of benchmarking and the speed with which we could get things if we're integrated like this with Epic, I think could be just huge.
So, I mean, I'm a huge fan of AQI since Rick Dutton's day and have had the privilege of watching some of it happen. But for quite a lot of our listeners who are not in the US, can you give them a flavor of who the data is being collected on? Is it everybody? Is it a sample, as I understand SQIP is, and what you're extracting from the electronic health record? What are the key outcomes, or can you look at everything?
Yeah.
I think Patrick's
so I think we said as part of the NACOR 1.0, if you will, like we said, a lot of that is administrative data, but where we're going is it's sites that have been willing to sign up and partner with us. So one unique thing about the AQI registries is we have a mix of academic, private practice, large practices, small practices, things like that. So we're trying to represent and get an adequate slice of practices across the United States.
And it's all patients having a major procedure and
any patient that goes through the perioperative arena.
Wow.
Yeah.
And can you link? So you've got an SQIP sitting over here. Is it possible to achieve linkage between the data sets to get added value?
Well, I think you're getting into some of the future that we'd like to be able to do. But in the past, that's difficult to do because the organizations haven't been partnered in that way.
Yeah, but lots of opportunity there for sure.
But I think that is absolutely a goal. I think at the end of the day, something that served me well just in my, clinical and administrative practice is at the end of the day, what does the patient need us to do? And in my world, what does the child need us to do?
Yeah.
It's really, they need us to all come together and figure out how to solve some of these problems that result in a lot of harm and even death of patients that is preventable.
Yeah.
And really optimize that.
So you mentioned Epic earlier, and Sheila, I think you mentioned about EMRs and integration in, and how it's difficult when we have billions and billions of data points, but we can't do a whole lot with them. So it's been necessary. It will be necessary going forward to find a way to partner with them. And so I think there's some really exciting news coming out from the AQI about how you're going to do that.
There is. I had the pleasure, I was on faculty at the last SDS quality conference and got to partner with some of the people that we may be working with in the future. So I think that there's a lot of opportunity there. So what's the innovation here in terms of why we're doing this? So you brought it up. So each individual site on their electronic health record, and probably more importantly, their AIM system, which stands for Anesthesia Information Management System, they have, like you said, millions of data points. Getting that data from that individual site to the AQI in a structured, standardized way is a much larger lift than most people would anticipate. You both may be familiar with it. People in informatics are very familiar with it, but getting that to work is very difficult. And then the other problem is you have a software company that continues to innovate. So things change. And in some cases with Epic, we're doing quarterly upgrades.
Yes.
Imagine 4 times a year, you're trying to go back and optimize all that, and you're having to run servers in your own shop. You need your IT teams. And for better or worse, this may not be the highest priority of your organization, comes at significant cost. Epic has something, an internal registry called Cosmos, which is where they're already taking data from individual sites, they're blinding it, and participants can use the data to answer research questions inside of Epic. So they built that structure, and they're doing some very fascinating things with it. That'd be fun to talk about at some point, but not today. But what we're looking at doing with Epic and what they built for us to be able to do is to take those data feeds from the individual sites, and instead of pointing them at Epic's registry, point them to the society.
Yep.
So we're able to know what patient, what information, and then that goes into the database at AQI. Then we can take data potentially from other EHRs, whether it's the Cerners of the world or others, mix that in, and then start to get a real picture, not just of the administrative data, but of the clinical data. Now, what's also fascinating about this is if you just go after the anesthesia data, that AIMS data, you're not getting all these longer term outcomes. When you're partnered with Epic in a EHR, a true electronic health record, you have all that. So now we can start to answer the questions like, when did they go back to work?
Right.
Yeah.
When did they go back to school?
Did they have a surgical site infection? Did they have an AKI?
Right.
And how that might happen
Yeah.
a long ways after. Because I think anesthesiologists don't always get the credit for the things we do. That
Get the blame
prevent
for
them
plenty of
happen.
things.
Right, exactly. But we have to parse apart what was our contribution and what was the surgical contribution, because right now, as you said, our contribution ends in the PACU or when we drop them off at the ICU. We know that's not reality. Reality is the decisions we make in the OR may have long-standing implications. We need to know exactly what they are and how to optimize them.
Well, this is where the value proposition comes
Right.
in, right?
Right. And what's great with anesthesia too, that when the surgeons are looking at the patients, they're looking at down their road. I'm orthopedics, I'm cardiac, I'm colorectal. Whereas in anesthesia, we're taking care of all of them. So if we make changes in one area, it's very easy for us to extrapolate it and use it across the board. So we can really make those quality improvements much more broadly, and also then watch the value a little bit more closely for all the different areas. And I think that's a huge one. Being able to link some of the post-op part to the intra-op, I think will be really powerful. And with Epic, it'd be very easy to do that in terms of just where that patient is, whether they come back from surgery in another 6 months, what was the last time, how did they do, those sort of things.
And then Epic has some interoperability features. So let's say the patient has surgery in one place and goes and gets care in a different place. Epic has communication between the sites. So we may be able to leverage that, and then we don't lose patients to follow up as many registries do.
Yeah, that's right.
Another real big advantage I see with this is a lot of us are moving from individual hospitals to health systems.
Yes.
So in my system, we have a couple of different hospitals. We have different styles of practice. We have some independent nurse anesthetists. We have physicians, directed solo physicians. This is a real opportunity to sort of say, okay, we have quality that we're looking at in all sites, bringing it back in a non-punitive way, that you're not poking into somebody's hospital or what they're doing. We're all one department then, and we can have equal benchmark across quality standards across, which I think this would be really valuable for.
Yeah, it's going to raise everyone up and improve quality of
and I
care
think-
for everyone.
And hopefully excite people. I think if you feel something's not working or you want to try something new, if you feel that then you may be able to measure it and look at it and change it, I think you're a lot more enthusiastic than what's the point in asking?
Yeah.
It's going to be, nobody will change anything.
Yeah,
So
it's a good
Oh.
change management tool.
excited.
And we see that all the time. So take the case of a very basic case we do, tonsillectomy. Say I have 50 anesthesiologists, 50 different ways to try it.
Right.
And you have somebody that's saying, well, I like to start with a little fentanyl.
I
and
get
mix
this
up
narcotic,
a lot of
Etomidine,
You mentioned dexmedetomidine, and I do this, and I like to wake them up, and I like to deep extubate.
Right.
What does that do to the PACU nurse? You can't define normal
Yeah.
Right.
because everything coming at you is different.
And you don't really know the outcomes, the right way to do it.
And in X types of kids, this would be better.
But right now, if you're Sheila and you approach the group
Right.
and say, I'd like to propose we do it this way, can you imagine the reaction? Where's the evidence? I like what I do. I'm good at it. I get great results. Well, how do you know you get great results? Well, because I get great results. It's like cooking.
I know. Oh, yes.
Yes, we are. And we want to get to the point that if we want to move from that to we have a structured recipe and we change the recipe, to your point,
Right.
we can say, oh, look, we changed it and things got better or things got slightly
Yeah.
worse. Now we're really driving something from a value-based perspective.
So, Mike, we're smiling at each other because this is our lane. We talk so much
Completely.
about.
Sounds like you have such rich information. How does it work for centres? Either you got patients who are moving within your system, but to centres without Epic, or if a centre doesn't have Epic, they're working on another provider. Is there a plan for that, or is this going to be a?
Yeah.
There's a plan.
Yeah.
I mean, when you look at all the EHR vendors out there, we knew we had to solve this problem of data acquisition. That has been the thorn in our side from the very beginning. It's just too much of a lift on those individual organizations.
Yeah.
Well, who are you going to partner with first, right? So we looked and had the right relationships with Epic, and Epic was willing to join us on this journey, build the tools we needed, and power this registry. So we partnered with them.
Right.
We're already starting the process of communicating with other EHR vendors, and we have to have a way to get data from everyone that wants to participate. We maintain it's the logical place to start because, frankly, they're the biggest here in the United States.
No implied criticism at all. Just
Yeah.
interested in the logistics and also the interoperability. If you start to extend out to other systems.
So there's two ways to approach that interoperability. One may be if they're interoperable with Epic, we may be able to get to it that way. The other opportunity is, remember, we're not hosting the registry with Epic, we're hosting it with the AQI. We get the data through the Epic registry, which means we can bring in additional data from other EHR vendors or even from other sources and put that in the overall registry. So it's kudos to AQI that we're still putting the resources in to maintain that internal registry. We're just going to get high fidelity, accurate, standardized data from Epic. And then we're going to take that same approach and go to, Cerner, now known as Oracle Health, and others, and say, see what we're doing here? We would really value your
Let's do this.
participation.
So in the UK, we have a so-called Office of National Statistics, and we can track deaths, for example. Is that something that's possible at a state or federal level?
The federal level.
So yeah, definitely your Medicare data, all of that is there.
CMS. Yeah, there's a lot of information.
It's a lot of the outcomes, yes, the 30-day outcomes, readmissions, deaths, that sort of stuff will all be. And then that will be, I'm assuming that will be easy to either correlate with or work together with in the data. And I think it's important for anesthesiologists to understand too, this is our registry. It's going to be about us, what we want to do with it, how we can empower our specialty to get even better and bigger and really show our perioperative value even more. And I think that's really important. It's not an Epic. Epic is obviously, central to this. The data is going to be fantastic. They're great to work with, but it is still coming back into an anesthesia registry. And I think that, that hopefully our members will feel trust in that, the ability to question and ask and use us.
I was going to ask that. So if you're an ASA member or not an ASA member, can you put in a request to address a particular question, that kind of thing?
Yeah, I think once we have this spun up, there's definitely going to be that opportunity. Get in a situation where participants may have a quicker path to that information for privilege of participation, but we still have a strong committee structure. Or if somebody approached the committee that even wasn't submitting data and said, hey, I think this is important, what do you all think? We would definitely take advantage of that question and answer it.
Yeah. Great.
Yeah.
We have some, as we wrap up here, Sheila, I think you are one of the first participants in the anesthesia community registry. Can you tell us a little bit about that?
Pretty excited. So up at Dartmouth, we really love data. We really value data. We've got lots of data. And I'm really excited that we haven't been, previously, I've been there about a year, we haven't been part of AQI, but we're going to be joining in then as a new partner with them then to set up this. We have Epic and then work together to set this up for our system. And it will be great because then it will be our main hospital, which is the big tertiary care, but we also have multiple smaller sites all moving to Epic. So I think it'll be a real opportunity.
Yeah, great.
Dartmouth loves data.
Yeah, all of us do. It's just how we use it and how we can get our hands on it. So it's going to be great. Well, it sounds like this is an evolving story. So we hope to catch up with you next year and hear how things have gone and how things are going and how we can get more involved, right? As no matter what type of practice that you're in, how you can get involved and get access to this kind of information to help drive quality.
I think our motto is no practice left behind. It's just how we approach prioritize that wants to work with us. We're going to find a way to work with them. It's just how we evolve to make sure we're getting the information we need to do that.
Yeah, fantastic. Well, thank you for all your work and your contribution to this space. It's really important.
Thank you.
Thank you so much. And thank you for listening to Top Med Talk. You know, you can always find us at topmedtalk.com. You can find us on your favorite social platform, your favorite podcatcher, wherever you do. Give us a thumbs up, give us a rating, give us some comments. We love to hear what you want to hear and what you love to hear, especially these conversations like that. So please do that. And we want to thank, of course, the American Society of Anesthesiologists for supporting us to be here to enable these types of conversations. So thanks so much, everyone. Cheers.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.